The American Brain Tumor Association is pleased to welcome you back to our webinar series. Today's webinar is titled Current Applications and Advances in Tumor Fluorescence and has been sponsored by NX Development Corp. Please note that all lines during our webinar today are muted. If you have a question you would like to ask, type and submit it using the question box in the control panel on the right-hand side of your screen. Dr. Sanai will answer questions at the end of his presentation. In the next few days, you will receive an email asking you to take a brief survey to evaluate the webinar. Please take a few minutes to share your feedback, which is important to us as we plan for future webinars. Today's webinar is being recorded. The recording will post to the ABTA's website on the Anytime Learning page shortly. Registered participants will receive the webinar recording link in a follow-up email message tomorrow. Our webinar today will be discussing current applications and advances in tumor fluorescence. My name is Christine Daly, Program Manager here at the American Brain Tumor Association. I'm delighted to introduce our speaker today, Dr. Nader Sanai. Dr. Sanai is an internationally recognized neurosurgical oncologist at the Barrow Neurological Institute in Phoenix, Arizona, with clinical and research expertise in the treatment of brain tumors. His neurosurgical practice is devoted entirely to patients with tumors of the brain and spine, including those in high-risk areas. And he also has extensive experience using intraoperative mapping techniques to maximize tumor removal while preserving crucial structures controlling motor and language function. As the Southwest's busiest neurosurgical oncologist, with over 2,500 brain tumor surgeries performed since 2010, Dr. Sanai was recently elected to the American Academy of Neurological Surgeons. Thank you for joining us, Dr. Sanai. You may now begin your presentation.
Well, thank you very much to the American Brain Tumor Association for inviting me to participate. As was stated, this will be a discussion on fluorescence-guided surgery. My name is Dr. Nader Sanai at the Barrow Neurological Institute. The discussion itself will really center on an FDA-approved drug called 5-aminolevulinic acid, which is otherwise known as 5-ALA. I will focus on, in particular, its applications in gliomas. The FDA indication for this drug is for high-grade gliomas. Fluorescence-guided surgery is really a mechanism and technique used to improve extent of resection in low and high-grade glioma patients. For the neurosurgical community, there's increasing evidence that greater extent of resection improves overall survival for both low grades and high grades. And what this means is that for any patient diagnosed with a presumed low or high grade glioma, the first step is really an operation designed to improve extent of resection, reduce tumor burden in those patients. What the data tells us is that for low grade gliomas, a surgeon really needs to remove at least 80% of that tumor on, at least as visible on the MRI, in order to achieve a survival benefit in patients. So reaching this minimum threshold is a central objective to any operation. In fact, if we look at the literature for extent of resection and the importance of surgery for gliomas that are low grade, and low grade gliomas are technically defined as WHO grade 2 gliomas for the purposes of this discussion, you can see the improvement in overall survival that you achieve in patients when you have a complete 100% resection versus those that are less than 100 or 90% in some of these studies. So this data has really been consistent across multiple investigators and cohorts. For low-grade gliomas, another key consideration is the time for malignant transformation. And we know that most low-grade gliomas are susceptible to transforming to become higher-grade tumors, but we also know that this interval is extremely variable. What we see from the literature is that when you achieve an aggressive extent of resection in these patients with low grades, you can change the timing and offset it as much as tenfold when it comes to the interval of time until what's called malignant transformation. So clearly reducing the tumor burden is a critical feature of any neurosurgical oncology procedure, But it's not just for overall survival benefit, it's also for improving transformation rates. And the third advantage of an aggressive operation is really changing the quality of life of the patient. And for low-grade glioma patients, that often means improving their seizure profile. And what, again, the evidence tells us is that with greater extent of resection, what one sees is not only better survival and malignant transformation rate, but actually better seizure control rates as well. And so on average, for patients who present with a low-grade glioma and seizures, a complete resection can make those patients seizure-free as much as 90–95% of the time. Now, when it comes to higher grade tumors, the evidence really is actually more robust in terms of supporting an aggressive operation up front. There have been some randomized studies in this field for these patients, and in those randomized studies where we randomize patients to biopsy versus a craniotomy, there's a clear survival benefit for those patients that undergo a craniotomy. So clearly a watch and wait type approach is not appropriate if there's a surgically accessible lesion. But even when we look at operations and we look at the relative success of physicians in achieving greater extent of resection, we clearly see a stepwise improvement in overall survival for newly diagnosed glioblastoma patients. And even when we look at sort of this intermediate range of extent of resection for tumors where you can't necessarily get 100% out, but maybe 70, 75, 80%, what one sees is that in this intermediate range, there's still clearly a survival benefit associated with any extent of resection above 78%. So this 78 to 80% threshold is really a consistent feature across newly diagnosed low and high-grade gliomas, and actually has also been demonstrated in recurrent glioblastoma as well. All the more reason for surgeons to really try to achieve as complete a resection as possible, but that has to be tempered against the risk of morbidity and side effects from the operation. So here we have data from hemispheric grade 2 gliomas, from specific subregions of grade 2 gliomas in the insula, from grade 3 gliomas, both in terms of extent of resection and survival, and finally from grade 4 glioblastomas. But importantly, what the data also shows us is that if one undertakes an operation and that leaves the patient with a new neurological deficit, whether it's a motor deficit or a language deficit, those deficits actually equate to poorer survival. So this balance between extent of resection and safety really has to be measured by the surgeon and the neurosurgical oncologist involved in the operation. And one can't justify taking more tumor out, for example, at the expense of neurological function. Now, if we look at the overall literature in terms of how surgeons perform in achieving what in the literature is termed as a gross total resection, what we see is that, in fact, that's not always what we arrive at in our operations, particularly for low-grade gliomas. About a quarter of the cases arrive at a gross total resection, which is certainly less than what one would hope. But even for high-grade glioma, it's about 2/3 of the operations that yield a complete or gross total resection. And interestingly, that number is very similar to what we see from a randomized study on the topic that I'll be speaking about shortly. So 5-aminolevulinic acid, or 5-ALA, that now goes under the trade name in the United States of Gliolin, is really an agent that was FDA approved in the spring in the United States for greater extent of resection. Now, this agent actually has been approved for many years in Europe, so we know a lot about it. We know that it's a very safe agent, and we know generally how it works. And the way it works is that this is an amino acid derivative, and patients ingest the material, usually in the form of a drink, the morning of an operation. And this 5-aminolevulinic acid then gets metabolized in tumor cells, but it gets metabolized in an abnormal fashion because of the abnormal signaling and chemical pathways within a tumor cell. And so for that reason, it gets stuck in its metabolism at a certain byproduct, and that byproduct is called protoporphyrin 9. And protoporphyrin 9, otherwise known as PplX, is the active metabolite that actually is the fluorescent agent in these cells. So for any type of glioma cell, low or high grade, because of the abnormalities in the cell, they will receive 5-aminolevulinic acid or 5-ALA, metabolize it to protoporphyrin 9. And the more actively dividing cells there are in the tumor, the more protoporphyrin 9 is accumulated. Now, this is, as I said, an orally administered drug. It's relatively non-toxic and safe. There's never been a major complication with the drug reported in the United States. And the interesting feature of it is that as that protoporphyrin 9 accumulates, under regular light, under an operating microscope, as you see on the panel on the left, it looks normal. But when one fluoresces that same field with a blue light along certain wavelengths through the operating microscope, it reflects back off of the protoporphyrin 9 in the red wavelength, and that's where you see this red evidence of residual tumor in this resection cavity. So this is what we call macroscopically visible tumor fluorescence. Now, in fact, for lower grade tumors, there's also microscopically visible tumor, and we'll talk a little bit at the end about different devices that can be used to visualize that microscopic tumor infiltration. But for high-grade gliomas, the application is quite simple. This is an operating video of a case where one has completed or has thought to have completed a tumor resection based upon the MRI imaging. But when we flip on the blue fluorescence, we can see the protoporphyrin 9 signal right within the center and off to the edges of this residual tumor. And so that tells us that there is residual tumor in that area. If we were to stop this operation here, there would be residual tumor on the contrast-enhancing MRI. But because we see this area, we can then make an assessment as to whether it's safe to remove this tumor or not. And that's a critical decision point for the surgeon. The presence of residual tumor does not necessarily necessitate its removal. That all depends upon the presence of functional pathways. And so for many of us, myself included, we rely heavily on intraoperative stimulation mapping to identify for us those functional pathways so that we don't inadvertently traverse them en route to resecting the tumor. Now, when we look at how this fluorescence lines up with the contrast-enhancing tumor, what we now know is that the fluorescence is actually more sensitive to visualizing tumor than gadolinium, the contrast-enhancing material in scans. And what that means from a practical standpoint is that if one removes all of the visible macroscopic fluorescence, then that effectively will have removed all of the gadolinium-enhancing tumor on this postoperative scan, in addition to a small, on the order of millimeters margin beyond that gadolinium enhancement. And this is how one uses this technique, fluorescence-guided surgery, to improve extended resection and maximize extended resection. Now, the data in support of the use of this drug is really most robust out of Europe. And these were studies that were the basis for the European approval of the drug. This is in particular a study led out of a German consortium where 260 patients were randomized. These were patients primarily with glioblastomas. And effectively what they did is they had a series of surgeons operate on these patients, and a surgeon would have the patient randomized to the presence of the fluorescence versus the absence of it. And these are operations, importantly, that did not use neuronavigation. And so that's a critical distinction to keep in mind. But nevertheless, if you look on the curve on the right, you see the separation in progression-free survival between the red line, which represents the patients that receive the fluorescence, versus the white light or control specimens in the black line. And what this really meant from a practical standpoint was that when we randomized to 5-ALA, or this fluorescent molecule, the patients that received the fluorescence ended up with twice as great a rate of gross total resection as patients that were randomized just to control drug. And this in turn equated, of course, to an improved progression-free survival And when the authors of the study went back and looked at overall survival, it also translated to a better overall survival, which is, of course, not surprising based on the data I showed you earlier that greater extent of resection leads to greater overall survival. However, this doubling of gross total resection was a very real and statistically significant finding, and that was really the basis for approval of this drug in Europe several years ago. Now, one of the challenges that we within neurosurgical oncology face with this drug is not so much the ease with which one can use it for contrast-enhancing high-grade gliomas. And here you see a classic image of this very vibrant red that clearly represents residual tumor that's very obvious for anyone in the field to see needs to be resected if it's safe. But in cases where you have transforming low-grade gliomas, such as the scans in the upper right, or highly necrotic high-grade gliomas, such as the scans in the lower right, there are many scenarios where one does not see the fluorescence in the middle of these tumors, as you can see in the videos in the upper left and the lower left. And the reason fluorescence is not visualized in these cases is not because there's not tumor there, but because the accumulation of protoporphyrin IX is just simply not dense enough in these particular cases to really enable macroscopic visualization with our eyes. Simply put, the fluorescent signal is just not strong enough because there's not enough of it. And this really has nothing to do with the tumor biology. The tumor biology is functioning as it would. It has to do with the limitations of intraoperative microscopy, and specifically the limitations of wide field microscopy. And that has to do with tumor density and the density of the fluorescence. We know that as you get to the center of a tumor, unless it's highly necrotic, there's going to be a lot of dividing cells there, and therefore you're going to see a lot of macroscopic fluorescence. But we also know that as you get to the periphery of these tumors or into necrotic areas where the number of proliferating cells are less dense, in those scenarios there's less fluorescence visible, and so these operating microscopes that we use just simply are not powerful enough to complement our own eyes' limitations to visualize this fluorescence. And so there have been studies looking at the relative degree of fluorescence, and certainly the absence of fluorescence does not necessarily imply the absence of tumor. And here you see a grading scheme out of another group in the United States that looked at tumor fluorescence at various degrees. And what one notes is that when you see fluorescence, there is a high degree of certainty that there is tumor there. That's what's called the positive predictive value. And so that's 97+%, which is exceptionally good for any biomarker. However, in the absence of fluorescence, when you don't see fluorescence, such as in panel 0 or 1, that doesn't necessarily mean there's no tumor there. And so the negative predictive value is relatively low at less than 40%. And this is, again, it doesn't have to do with the biomarker or the 5-ALA performance, but rather the performance of the microscopes that we use to visualize it. And here's an example of an operation within the center of the tumor where there is no obvious fluorescence. For lower grade tumors in particular, this is a very strong challenge because most low grade tumors do not give you macroscopic fluorescence. And what this one study shows is that when you do see any fluorescence in a low-grade tumor, this is often in a focal fashion, not uniformly across the tumor, and those pockets typically represent areas of that low-grade that are beginning to transform into higher-grade WHO grade 3 and 4 gliomas. So for low-grade tumors, this is still an off-label indication, but it's something that can have value depending upon whether there's areas of transformation, depending upon the histology, and also depending upon the equipment used in the operating room to visualize the tumor. And for the surgeons in the audience, I can advise you that the drug itself, which is under the trade name of Gleolan, is commercially available and can be purchased through your pharmacy at the hospital for use in the operating room. It's typically administered to patients somewhere on the order of 4 hours, 2 to 4 hours before a planned operation, and there's a standardized dosing for it. It is a liquid that patients ingest in the preoperative area. But what one needs in the operating room are specially equipped microscopes to visualize this fluorescence. And these microscope fluorescence packages are available through any of the major operating microscope vendors at an additional cost. Now, when one looks at expanding the use of this kind of agent or this kind of technology or technique into low-grade tumors, one has to be confident that when you do see fluorescence at very low levels, and here you see at a high-powered microscope level 2 individual cells that are fluorescing with 5-ALA, that in fact represents tumor. And so what we and others have shown is that at a cellular level, you can purify these individual protoporphyrin IX positive cells. You can confirm that they have the same abnormal karyotypes or genetic malformations as their parent glioma tumors. So this indicates that these are actually abnormal glioma cells with protoporphyrin IX. And you can also confirm that these are not abnormal inflammatory cells, for example, giving you a false positive signal. And here you see some inflammatory biomarkers that don't co-localize with protoporphyrin IX. And you can also confirm that these cells are not progenitor cells. These are not neural stem cells that are normal in the adult human brain that happen to be abnormally accumulating protoporphyrin IX, and in fact they don't. And specifically, they are not glial progenitor cells, which are pervasive throughout the white matter of the subcortical adult human brain. And these glial progenitor cells that can also be sorted out do not accumulate porphyrin IX. So what this tells us altogether is that this is an exceptionally accurate, with a high positive predictive value biomarker. And the limitations of it really have to do with the technology we have available currently in terms of visualizing it as sensitively as possible. And this is where the development of new investigational handheld devices has come into form in recent years. This first generation device is a handheld confocal microscope, which is effectively an investigational device that's the size of a suction that's navigable in the operating room, and you can see its size relative to the brain surface in the lower right panel. And in the operating room, what one can do is, in cases of low or even high-grade tumors that have no macroscopic fluorescence, and this video shows you the blue fluorescent light under macro showing you no real evident fluorescence, one can point and shoot with this handheld confocal and basically visualize microscopically the presence of infiltrating tumor cells. And these are the tumor cells that really do escape us at surgery because they're not often visible even on an MRI. And what you can see in the upper right is a negative visual field with the handheld confocal, and in the lower right, a positive one showing this starry sky of 5-ALA or protoporphyrin IX positive cells. One can confirm this with a variety of other microscope technologies, including a desktop confocal microscope that you see here. And we and others have reported our experience with these types of approaches. This was our experience out of the Barrow Neurological Institute nearly 8 years ago, demonstrating that for low-grade gliomas, where it appeared that there was no macroscopic fluorescence, one could use this handheld device to visualize at multiple points during the operation, not just at the initial or midpoint of the resection, but even at the margin, when one believed that one was completed with the resection based on the intraoperative navigation. We would identify cases where there was clearly more tumor to be had. In some cases, we couldn't resect further because there were functional boundaries that limited us, and in other cases, we could push the extent of resection even further, which was the objective of the operation. And as these devices have become more sophisticated, one can actually visualize with much more detail the morphology of even the tumor cells that one sees, which can also give you an idea of what kind of tumor grade or abnormality you're dealing with. Now, the final piece to this puzzle is really trying to get a quantifiable metric here, meaning in today's day and age, the success or relative success of a brain tumor operation is measured based upon an MRI. We take the patient to the operating room, remove their tumor, get a postoperative MRI. If it's a glioblastoma, for example, that will be a postoperative MRI with contrast. And then we'll measure how much contrast-enhancing tumor is left after the operation, and that gives us an extent of resection measurement. But that's really just the tip of the iceberg for these tumors. And what we really want to do is be able to push these extensive resections beyond really radiographic metrics, beyond simply contrast enhancement, for example, and really to the edges of the tumor infiltration itself. And this is sort of akin to, for example, taking margins within a breast cancer operation in order to assess the extent of residual tumor within the margins of one's resection. Obviously, within the brain, surgeons can't take margins because the tissue is so valuable. But with a device like this, one can generate a quantifiable heat map where one can understand what is the microscopic tumor burden at the residual margins of this disease. And that can in turn inform the surgeon as well as the radiation oncologist and the neuro-oncologist in terms of what areas of the resection cavity are at risk for recurrence, what is the relative tumor burden at those margins, and should we be concentrating, for example, adjuvant radiotherapy along some of those more at-risk margins based upon what we see with microscopic tumor fluorescence using 5-ALA. And as we see the future unfold, it's almost a certainty that 5-ALA is just going to be the first of many different fluorescent-guided molecules that will become available for patients. Many of these molecules in the future will likely be more molecularly binding, and as a consequence will tag certain receptors and subtypes of glioma cells and other tumor types as well. And so this means that we're going to have to develop technologies that really accommodate a variety of different fluorescent signals, not just the blue and red that one uses for 5-ALA and gliolin, but rather other wavelengths of light for simultaneous visualization. And that's something that I think will be coming down the pipeline very soon. So to summarize the real state of fluorescence-guided surgery for primary brain tumors today, the real utilization of it currently is in high-grade gliomas, but the fact is that 5-ALA-based fluorescence can be visualized in all tumor types within the glioma category, WHO grades 1, 2, 3, and 4. The specificity of this molecule is extremely high. The positive predictive value is extremely reliable. However, this is also importantly a molecule that will not give you false positives, and that's a very critical factor in terms of assessing the safety of using this technique. And we can see that we're going to see increasingly expanded indications in the future for fluorescence-guided surgery. This is going to be assisted by the development of new intraoperative and perioperative adjuvant technologies such as the handheld confocal microscope, in addition to other types of fluorophores to visualize other fluorescent targets. And all of this, as always, really needs to be adopted early by the neurosurgical oncologists and brain tumor centers of excellence so that one can get past the learning curve and really incorporate it into what it really should become, which is effectively a standard of care type technique for the neurosurgical oncologist. So with that, I will conclude this talk. There's this disclaimer at the end provided by the ABTA, and I will thank you again for joining us and open it up to any questions.
Thank you, Dr. Sanai. We will now take questions. If you have a question you would like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen. We do have a couple of questions already from registration, so I'm going to just get started with those. One of our first questions is, can the 5-ALA be used with brain mapping?
That's right. So that's a good question. Can the fluorescence-guided surgery be used simultaneously with brain mapping? And the answer is absolutely yes. In fact, the two things are very complementary because the brain mapping tells you where the functional boundaries of the tumor are, and the 5-ALA tells you where the structural boundaries of the tumor are.
Great, thank you. Our next question is, are there other fluorescence tools that would work for non-gliomas?
So the question of fluorescence-guided surgery for non-gliomas is an interesting one. 5-ALA, for example, has been tried in a variety of different tumor types at an investigational level. It's been tried for brain metastases. It's been tried for high-grade or aggressive meningiomas. It's been tried for high-grade or aggressive ependymomas. And in many of these cases, you do see fluorescence. However, we don't have the kind of data we have for gliomas to prove that this fluorescence actually improves clinical outcomes the way it does for glioblastoma. So it is an off-label use of the drug, and it can be done in those circumstances. In terms of other types of fluorescent technologies, and that really refers to other fluorescent molecules, there is another fluorescent technology that's currently available called fluorescein. And fluorescein is an intravascular contrast agent. It's used oftentimes in aneurysm surgery to look at blood vessel integrity. But because blood vessels are somewhat leaky in brain tumors, the fluorescein can leak into a brain tumor as well. So there are studies underway looking at that molecule. However, a key distinction to remember with fluorescein versus 5-ALA is that fluorescein is not a specific biomarker. It doesn't have any properties that specifically label brain tumors themselves. 5-ALA is a specific label that only applies to brain tumors. Fluorescein really will go into any area of the brain with a leaky blood vessel. And so for that reason, it's much more challenging to use as an extent of resection device for any tumor type.
Great, thank you. Next question is this technology available in Canada?
That's a great question. I don't know what the regulatory status is of 5-ALA in Canada.
Okay, we can follow up on that. Does scar tissue light up with the fluorescence or only the tumor?
That's a great question as to whether scar tissue lights up with the fluorescence. Scar tissue is often a colloquial term used in the operating room for what's called radiation necrosis, or another word for it is treatment effect. And in all cases, it means the same thing. It implies that it's dead tissue that doesn't have live tumor in it. And for practical purposes, there is really no meaningful fluorescence from scar tissue or radiation necrosis or treatment effect with 5-ALA. However, as we know, many times scar tissue or radiation necrosis is not purely dead tissue. It can be a mixture of dead tissue intermingled with live tumor. And so in those cases, what one thought is scar tissue, but actually turns out to be a mixture of live cells and dead cells, those scenarios can fluoresce with 5-ALA. And this is why the surgeon still has to make a lot of interpretations in the operating room when you're using this kind of technique.
Great, thank you. Our next question is, do you think that this new technology could help with tumors that were previously determined to be inoperable, or whether that would determine any new approaches to treat it?
Yes, so the question really has to do with how this technology or technique improves complex or difficult to operate upon tumors. The answer really depends upon why a particular tumor is deemed inoperable. In some cases, for example, with a glioblastoma that's truly multifocal, where it's in different regions of the brain and sometimes different hemispheres, the use of technique like this doesn't change that. In those patients, an operation to remove the tumor is really not in their best interest, and so this does not change that scenario. In other cases, however, where a tumor, for example, might be in a difficult to access location, the presence of 5-ALA doesn't make it any easier to access that location in the brain. That simply has to do with the surgical techniques of the surgeon and their comfort level in operating in certain areas of the brain. But what it does do is that when the surgeon arrives at that region of the brain, there's probably less of a likelihood that they're going to get disoriented or somewhat lost when it comes to the boundaries of the tumor. And in those delicate areas of the brain, those boundaries are very critical to respect, and the 5-ALA can help with that in some cases.
Thank you. Next question, is 5-ALA used by neurosurgeons at all brain tumor centers, and if not, why?
So 5-ALA was approved for FDA approval by the FDA in the spring of 2018. Since then, there's now been a system developed in the United States to give centers access to the drug. One of the stipulations from the FDA was that for a surgeon to use this fluorescent molecule, there needed to be some basic training provided to the surgeon in order to be safe with the technique and up to date. So there were a number of centers in the United States that were designated as centers of excellence. Two of the major ones in the U.S. on the East Coast is at Mount Sinai in New York City, and in the West United States is in Phoenix at our institute at the Barrow Neurological Institute. And these are centers that provide training to get surgeons familiar with the technique. There's also online modules. So as surgeons become more familiar with it, we see more and more sites adding it. Certainly this is a drug and a technology that should be available at every major brain tumor center, but we're still in the growth phase of that trend.
Great, thank you. I think this is our last question. Is this able to be utilized with children?
That's a great question as to whether or not 5-ALA can be utilized in the pediatric population. Currently, it is not approved for pediatric brain tumors. However, we are starting to see investigational protocols at some select pediatric brain tumor centers where they use the drug on an investigational basis. This is really the first step towards getting the drug approved in the pediatric population. What really needs to be done is that there needs to be more robust safety data from the pediatric population in order to convince the FDA to approve it for them. So right now, it is not FDA approved for that indication. However, as part of a clinical trial, it can still be accessible at certain centers.
Great, thank you. That's all the time that we have for today. Thank you all for joining us, and thanks once again to Dr. Sanai for his wonderful webinar presentation. Besides our free educational webinars, ABTA has a variety of programs available to help connect patients and caregivers with information and resources to help support them in their brain tumor journey, as well as publications and resources for healthcare professionals. For more information, visit ABTA's website at www.abta.org or call the ABTA Care Line at 1-800-886-2282. This concludes our webinar. Thank you for joining us, and please be sure to complete the evaluation survey you will receive by email within the next 2 days. You may now disconnect.